Welcome to today's New York Medicaid EHR Incentive Program webinar. Today's topic is Modified Stage 2 for payment year 2018. Please note that payment year 2018 is the last year that you may attest to Modified Stage 2. Stage 3 is required for 2019 on. We anticipate that many of you are joining us today because you are preparing for payment year 2018 Meaningful Use Attestation. Some reminders: there is no Meaningful Use workbook, and the full attestation will be available to complete in MyPass. This includes eligibility information, MU objectives, and clinical quality measures. MyPass accepts electronic signatures, which means that the MyPass attestation no longer needs to be printed, signed, dated, and mailed to New York Medicaid. We expect that this may expedite the time that it takes for providers to complete the attestation, and also for New York Medicaid to review the attestation. We start today by reviewing program eligibility information. We then give an overview of each of the objectives and measures for Modified Stage 2. We move on to talk about CQM reporting and wrap up with some program reminders and key takeaways. Here we have listed some acronyms. We know there are a lot of them, and these are just some of our most commonly used. You can also find an acronym glossary that was created by the Medicaid EHR team, MET, on behalf of and approved by the CMS Medicaid High-Tech team. We start with a brief overview of program eligibility. This next section will outline program requirements and the patient volume requirements in order to be eligible for the EHR incentive program. Likely, most of you are returning meaningful users, so this first section will be a review. It is still important to go over since meeting these requirements is required for each payment year. For each payment year, eligible professionals have a predetermined set of requirements. When we talk about eligible professionals, we're talking about the professionals on this list. Please remember to attest for payment year 2018 and forward. You must have received payment for payment year 2016 or earlier. That includes payment for AIU, Adoption Implementation Upgrade. To attest to Modified Stage 2, providers must have at least the 2014 edition of Certified EHR Technology. Providers can also use a combination of the 2014 and 2015 editions, or may use the 2015 edition exclusively. The proposed 2017 final rule required EPs to adopt the 2015 edition for program year 2018. However, the CMS finalized their rule, allowing healthcare providers to continue to use the 2014 edition cert for program year 2018. This means that providers who were previously scheduled to attest to Stage 3 in 2017 or 18 can continue to attest to Modified Stage 2. If you need to register for your Certified EHR Technology ID, please visit chpl.healthit.gov. The link is provided on this slide. Here we see the MyPass sign-in screen where you will enter your username, password, and CMS registration ID number. You will read and click that you accept the terms and conditions. Please review the provider's registration information. The email address on the registration serves as the primary contact for the provider participating in the New York Medicaid EHR Incentive Program. If the information displayed is correct, click Begin Attestation to proceed forward. If it is not correct, go to the CMS Registration and Attestation System to update the provider record. It may take up to 1 business day for the information to be updated in MyPass. Please make sure to update the provider's CMS registration before submitting the attestation in MyPass. If you have any pending attestations, making a change will cancel that previous pending attestation. Prior to attesting, the provider must have obtained an ePACES user account with MyPath privileges. Please also ensure that you are enrolled in Medicaid fee-for-service and that your payee affiliation is up to date throughout the entire process, including payment. The EP summary page displays the status of each section in the attestation: eligibility, objectives, and clinical quality measures. Each section must be passed in order for the EP to submit the attestation. When you click Edit for the eligibility section, you must answer these two questions that are next and enter the attestation payment year for your submission. Well, let's talk about what you need to know to answer these two questions. To be considered a meaningful user, an eligible professional must answer these questions. Do a combined 50% or more of your patient encounters occur at locations equipped with certified EHR technology? For example, if you have 100 patient encounters during the EHR reporting period, did at least 50 of those encounters occur at locations equipped with certified EHR technology? The second question is also a yes or no question. Do at least 80% of unique patients have stored data in your certified EHR technology during the EHR reporting period? Note that this is asking about unique patients. You will not use the number of encounters. You will use the number of unique patients from those encounters from your locations equipped with certified EHR technology. For example, look at your locations that have certified EHR technology. You may have had 50 encounters from 10 patients. Do 80%, at least 8 of those 10 patients, have data stored in certified EHR technology? There is one more thing you need to know here. The provider must report on meaningful use data from all of their locations that are equipped with certified EHR technology during the reporting period they have chosen to use. In our example on the previous slide, the EP must report on meaningful use data from all 5 of their locations equipped with certified EHR technology. There are a couple of additional questions to determine your eligibility, and on the next few slides, we'll break down this information. Medicaid patient volume. Remember, this is one of the eligibility requirements, so please make sure that this is calculated correctly and meets or exceeds the threshold. For each payment year, eligible professionals must meet one of the following conditions. 30% of the provider's patient volume must be from Medicaid recipients. For pediatricians, 20% of patient volume can be from Medicaid recipients, and this will result in the provider being awarded 2/3 of the incentive payment. If the pediatrician meets the 30% Medicaid patient volume requirement, they would receive the full incentive payment. Eligible professionals who practice predominantly in a federally qualified health center or rural health center are additionally eligible to use the needy patient volume calculation to meet the Medicaid patient volume requirement. The needy patient volume allows an eligible professional to add additional counter types to the numerator of the patient volume calculation. Now that we've defined a reporting period, let's review what constitutes an eligible encounter. This table helps summarize the encounter data that a provider is able to include in his or her attestation. If the provider does not practice predominantly in a federally qualified health center or rural health center, he or she is eligible to attest to Medicaid encounters, including Medicaid fee-for-service and Medicaid managed care. If the provider does practice predominantly in a federally qualified health center or rural health center and opts to use needy patient volume, the provider can attest to the encounters that are Medicaid fee-for-service, Medicaid managed care, and can also include Child Health Plus, uncompensated care, and sliding scale. A patient is considered a needy individual if they meet one of the following conditions. 1, the patient receives medical assistance from Medicaid or Child Health Plus, or the patient is given uncompensated care by the provider, or finally, the patient is furnished services, either at no cost or a reduced cost based on a sliding scale which is determined by the individual's ability to pay. Please answer no if the provider is using the standard patient volume method. Proceed to the eligibility information section. Answer yes if the provider is using the needy patient volume method and complete the field. Now it's time to choose your MPV time period. The Medicaid patient volume, or MPV reporting period, must be a continuous 90-day time frame that either begins and ends during the previous calendar year or takes place during the preceding 12 months from the date of attestation. Let's take a look at an example. In our scenario, our provider is using the previous calendar year and is attesting to 2018 meaningful use. The date of attestation is June 10th, 2019. The provider can attest for any consecutive 90 days beginning on or after January 1st, 2017, and ending on or before December 31st, 2017. Or the provider may choose to use the 12 months preceding the date of attestation method. In this example, the provider may choose to show a 90-day consecutive reporting period that begins on or after June 10th, 2018, then ends on or before June 10th, 2019. Please be careful when choosing your dates. An EP cannot utilize the same Medicaid patient volume reporting period or overlapping MPV reporting periods for multiple payment years. Complete the rest of the questions on this page to determine your eligibility. Do you practice as a pediatrician? Do you practice as a physician assistant? If the provider answered no to the previous question about practicing at an FQHC or RHC and is using needy patient volume, MyPass defaults the patient assistant answer, physician assistant answer to no. If the physician assistant wants to attest to the standard patient volume method, please review our frequently asked questions on our website for a workaround procedure. Hospital-based provider is defined as a provider who furnishes 90% or more of his or her covered Medicaid services in either inpatient, code 21, or emergency department, code 23, of a hospital. Hospital-based providers do not qualify for the Medicaid electronic health record incentive payments. This determination is based solely on the individual provider's covered Medicaid services during the calendar year immediately preceding the payment year. For example, if the provider is attesting for payment year 2018, then calendar year 2017 is used to determine hospital-based status. Include organization encounters. If you want to use the group aggregate method, answer yes. After selecting yes, a field will display where you must enter the organization NPI. Using the group aggregate method means that all group members must attest to the same MPV data. If you do not want to use individual patient volume, answer no to include organization encounters. See our frequently asked questions on our website for more details. On this screen, you will enter your total Medicaid encounters and the total encounters. There is more information on our website, including a patient panel decision tool that could help with the alternate patient panel method. If the provider answers yes to include encounters outside New York, they will be prompted to indicate which state. To calculate your MPV, you will divide your numerator, which is total Medicaid encounters, by your denominator, which is total encounters. For the alternate calculation method, you will add Medicaid patient panel and Medicaid encounters total, and divide that from the total from adding patient panel and total encounters. Next, we discuss an overview of Modified Stage 2 Meaningful Use Objectives. EHR certification information. This is where you start entering meaningful use information, including EHR reporting period and CQM reporting period. These dates must be within calendar year 2018. For 2018, they have options to attest either to Modified Stage 2 or Stage 3. Enter the EHR certification number. If using more than one cert, please go to the CHPL website to obtain a single EHR certification number. After clicking Save, a window will display confirming if you have passed the requirements for eligibility. If not, any errors in red text will display at the top of the page. You may remember this screen from earlier. Notice that eligibility now has a green check mark to indicate that that section is complete. CMS passed a final rule that states all providers must have a continuous 90-day EHR reporting period for 2018. Meaningful use data must be from the calendar year that the eligible professional attests to. For example, if a provider attests to 2018 meaningful use, the continuous 90-day period must begin and end in the calendar year of 2018. This may be a different time period than the provider's MPV reporting period. Modified Stage 2 establishes 10 objectives with variations of thresholds and activity on each objective. Eligible professionals are required to either meet the measure or qualify for an exclusion to the measure. On the upcoming slides, we will look at each of the objectives at a high level. Objective 1, protect patient health information, which involves conducting a security risk analysis. Conducting a security risk analysis is required when certified EHR technology is adopted. When changes to the practice or electronic systems occur, a review must also be conducted. Any security updates and deficiencies that are identified in the review should be included in the provider's risk management process. EPs are required to conduct an accurate and thorough analysis of the potential risks and vulnerabilities to the confidentiality, integrity, and availability of electronic protected health information, EPHI. Once the security risk analysis has been completed, the EP must take any additional reasonable and appropriate steps to reduce identified risk levels. Objective 1 is required and there are no exclusions. This objective can be particularly difficult for providers, so we want to direct your attention to a tip sheet that is offered on the CMS website. The tip sheet also talks about creating an action plan, security areas to consider when conducting your analysis, an overview of the objective, and steps to performing a security risk analysis. This document is a nice first step, and if the provider has additional questions, it also links to other helpful resources through the ONC. Objective 2, clinical decision support. This objective has two measures, and eligible professionals must satisfy both. For Measure 1, the eligible professional must implement 5 clinical decision support interventions related to 4 or more clinical quality measures. There are no exclusions to this measure. For 2018, CMS aligned the specific CQMs available to eligible professionals participating in the Medicaid EHR Incentive Program with those available to clinicians reporting eCQMs via their EHR for the Merit-Based Incentive Payment System, or MIPS. Measure 2 involves enabling and implementing drug-to-drug and drug-to-allergy interaction checks for the entire EHR reporting period. Any provider who writes fewer than 100 medication orders during the EHR reporting period can request to be excluded from this measure. Objective 3, computerized provider order entry. Eligible professionals must satisfy all three measures, including writing more than 60% of their medication orders, 30% of their laboratory orders, and 30% of their radiology orders using computerized provider order entry. Exclusions to this objective pertain to any provider who writes fewer than 100 medication, lab orders, or radiology orders during the EHR reporting period. An EP must satisfy all three measures for this objective through a combination of meeting the thresholds and exclusions. Objective 4, electronic prescribing. More than 50% of permissible prescriptions written by the provider are queried for a drug formulary and transmitted electronically using certified EHR technology. Any provider who writes fewer than 100 permissible prescriptions during the EHR reporting period can request an exclusion from this objective. Providers can also request an exclusion if they do not have a pharmacy within their organization and there are no pharmacies that accept electronic prescriptions within 10 miles of their practice location at the start of the EHR reporting period. Threshold measures such as electronic prescribing require numerator and denominator data. If the EP qualifies and claims an exclusion for a measure, the remaining fields are grayed out. Objective 5, an eligible provider that transitions or refers their patient to another setting of care or provider of care must meet Objective 5, health information exchange. The provider must use their certified EHR technology to create a summary of care record and electronically transmit the summary to a receiving provider for more than 10% of transitions of care and referrals. An eligible provider can request an exclusion from this objective if they transfer a patient less than 100 times during the EHR reporting period. Objective 6, patient-specific education. Patient-specific education resources are provided to more than 10% of all unique patients seen by the eligible professional during the EHR reporting period. The only exclusion to this objective would be if the EP does not have any office visits during the EHR reporting period. The EP must use elements within certified EHR technology to identify educational resources specific to patient needs. Certified EHR technology is certified to use the patient's problem list, medication list, or laboratory test results to identify the patient-specific educational resources. The EP may use these elements or may use additional elements within CERT to identify educational resources specific to patient needs. The EP can then provide these educational resources in a useful format for the patient, such as electronic copy, printed copy, electronic link to source materials through a patient portal or PHR. The education resources or materials do not have to be stored within or generated by the CERT. Objective 7, medication reconciliation. Medication reconciliation must be performed for more than 50% of all new patients who transition into the care of the provider during the EHR reporting period. Only patients whose records are maintained using certified EHR technology must be included in the reported numbers. In the case of reconciliation following transition of care, the receiving EP should conduct the medication reconciliation. The electronic exchange of information is not required for medication reconciliation. The measure of this objective does not dictate what information must be included. Information included in the process of medication reconciliation is appropriately determined by the provider and patient. We define new patient as a patient never before seen by the provider. A provider may use an expanded definition of new patient for the denominator that includes a greater number of patients for whom the action may be relevant within their practice, such as inclusion of patients not seen in 2 years. If a provider does not have any new patients who transition into care during the EHR reporting period, they can be excluded from this objective. Objective 8, patient electronic access. There are 2 measures, and eligible professionals must satisfy both. Measure 1, timely access to view online, download, and transmit health information to a third party is provided to more than 50% of all unique patients seen by the provider during the reporting period. Measure 2, more than 5% of unique patients seen by the EP during the reporting period, or his or her authorized representatives, view, download, or transmit to a third party their health information during the reporting period. In order to meet this objective, information must be made available to patients electronically within 4 business days. At a minimum, it must include patient name, provider name and office contact information, current and past problem list, procedures, laboratory test results, current medication list and medication history, current medication allergy list and medication allergy history, vital signs such as height, weight, blood pressure, BMI, and growth charts, smoking status, demographic information such as language, sex, race, ethnicity, date of birth, care plan fields including goals and instructions, any known care team members including the primary care provider of record. The EP may also include additional information if they choose. Any EP who neither orders nor creates any of the information listed for inclusion as part of the measures, or who conducts 50% or more of his or her patient encounters in a county that does not have 50% or more of its housing units with 4 megabytes per second broadband internet availability. Additional information on the details of satisfying this measure can be found on the Patient Electronic Access tip sheet on the CMS website. Objective 9, secure electronic messaging. In 2018, more than 5% of patients seen by the provider during a reporting period must be sent a secure message using the electronic messaging function of the certified EHR technology. A provider can request an exclusion from this objective if they either do not have an office visit during the EHR reporting period, or the provider conducts 50% or more of his or her patient encounters in a county that does not have 50% or more of its housing units with 4 megabytes per second broadband internet availability. The last objective, Objective 10, public health reporting. For this objective, the provider must satisfy 2 of the 3 measures. Measure 1 is immunization registry reporting. For this measure, the provider must actively engage with a public health agency to submit immunization data and receive immunization forecasts and histories from the Public Health Immunization Registry Immunization Information System. Any provider who does not administer immunizations to any population for which data is collected by its jurisdiction's registry or information system during the EHR reporting period can request an exclusion from this measure. Measure 2, syndromic surveillance reporting. For this measure, the provider must actively engage with a public health agency to submit syndromic surveillance data from a non-urgent care ambulatory setting where the jurisdiction accepts syndromic data for such settings, and the standards are clearly defined for EPs. Any provider who is not in a category of providers from which ambulatory syndromic surveillance data is collected by their jurisdiction's syndromic surveillance system can request an exclusion from this measure. Last, Measure 3 is specialized registry reporting. The provider must actively engage with a public health agency to submit data to a specialized registry. The provider can request an exclusion from this measure if the provider does not diagnose or treat any disease of a condition associated with or collect relevant data that is collected by a specialized registry in their jurisdiction during the EHR reporting period. Again, of these three measures, the eligible professional must satisfy two. You may be wondering what is considered active engagement. To fulfill active engagement, providers have three options. Option 1, completing registration to submit data. The eligible provider is registered to submit data with a public health agency or clinical data registry to which the information is being submitted. Registration was completed within 60 days after the start of the EHR reporting period, and the provider is awaiting an invitation from the public health agency or clinical data registry to begin testing and validation. Active engagement option 2, testing and validation. The provider is in the process of testing and validation of the electronic submission of data. Providers must respond to requests from the public health agency within 30 days. Failure to respond twice within an EHR reporting period would result in that provider not meeting this measure. Active engagement option 3. The eligible provider has completed testing and validation of the electronic submission and is electronically submitting production data to the public health agency or clinical data registry. For more information on this objective, please sign up for our public health reporting webinar. You can also review the information on our website or contact our support team. This is the screen where you will answer the public health questions. Note that at the bottom, if the EP is attesting active engagement for a measure, then the public health agency name must be entered. Click Add to enter additional names, and there is a maximum of 3. Providers who are in active engagement option 1 should register intent to meet the meaningful use for the public health reporting objective by using the Meaningful Use Registration for Public Health, or MRF system. Please note that this is only for the New York State Department of Health and New York City Department of Health and Mental Hygiene registries that are supported by MRF. If a provider is participating with a separate specialized registry outside the registries we support, they would register directly with that registry. The purpose of the MRF system is to allow eligible hospitals and eligible professionals to declare their intent to submit data to the New York State Department of Health and the New York City Department of Health and Mental Hygiene in support of the Meaningful Use Public Health Reporting objective. Eligible providers who intend to meet any of the public health reporting measures must register using this system. Registration must be completed before or within 60 days of the start of an eligible provider's EHR reporting period. In order to access and use the MRF application, you will need a Health Commerce System account, HCS. If you do not have an account, apply by following the directions located in the paperless HCS user account. Now that you've entered your objectives, you will see that under the status column, each has a green check mark to indicate that the answers to the objectives or their exclusions have been completed. After all meaningful use objectives have been completed, you can then continue to the clinical quality measures. Moving on, we'll talk about CQM reporting. Please note that for 2018 meaningful use, all CQM reporting will be completed in MyPass for this program. Clinical quality measures. There are 8 recommended adult measures and 8 recommended pediatric measures. We have those listed on the next couple of slides. Before we move on, though, we want to point out the clinical quality measure domains. Just a quick reminder, they are patient and family engagement, population and public health, efficient use of healthcare resources, patient safety, care coordination, and clinical processes and effectiveness. If you attested in payment year 2017, You may remember that the 2017 Clinical Quality Measure reporting period was a minimum 90-day period. For 2018, providers must report CQMs for the full year. However, if you are demonstrating meaningful use for the first time, your 2018 CQM reporting period is a minimum 90 days in the calendar year. The number of CQMs that EPs must report on has been reduced from 9 to 6. These 6 can be from any policy domain, but they must be relevant to the EP's scope of practice. Finally, CMS selected all clinical quality measures to align with the Department of Health and Human Services National Quality Strategy priorities for healthcare quality improvement. CMS also reduced the overall pool of CQMs from 64 to 53. These now align with those available to clinicians reporting eCQMs via their EHR for the Merit-Based Incentive Payment System, or MIPS. Likely eligible professionals may be able to use the same eCQMs for both programs. For more information on MIPS, please visit www.qpp.cms.gov. One final note, the CQM reporting period may be different from the EHR reporting period. If you choose to complete the adult clinical quality measures, this slide shows the 8 recommended adult clinical quality measures. This slide shows the 8 recommended pediatric clinical quality measures. If you have questions on CQM reporting, please feel free to contact our support team or visit the resources on our website. As we stated in the beginning, the attestation is completed entirely in MyPath, including e-signature. Please remember to download and save a copy of your MyPath attestation. Why is this so important? The integrity of the program is crucial. In light of the possibility of post-payment audit, providers are required to retain documentation in support of all attestations for no fewer than 6 years after the date of attestation. Some examples include date-stamped reports generated from the EHR system, screenshots of the EHR system's interface, and dated correspondence with the public health registries. Providers should be aware that all information submitted during registration, attestation, and any subsequent validation and audit procedures must be backed by auditable data sources or documentation. If you have additional questions on best practices for record keeping and audit preparation, you can access the audit section of our website. For more post-payment guidance, you can email hitech@omig.newyork.gov. We wrap up this webinar with some program reminders and general information. There are several resources available to you if you need assistance with your MU attestation. As always, you can access the tools available on our website or reach out to our support team. We'll show you these and additional resources that you can access in a manner that is most comfortable for you. For example, some EPs may choose to come to our webinars for an overview and then review our website and tutorials independently. Other EPs may prefer one-on-one assistance. We want to make sure that we're providing the most appropriately usable and useful materials and services. There are additional free services available to you from external sources. Regional Extension Centers, RECs, work to optimize the use of EHRs so that providers can become meaningful users. They help EPs engage in new healthcare transformation and quality initiatives, and they participate in payment delivery reform programs. New York State has 2 RECs that provide support services to healthcare providers as they navigate the EHR adoption process and achievement of meaningful use. If you are inside the 5 boroughs of New York City, you can contact the NYC Regional Electronic Adoption Center for Health, NYC REACH. If you are anywhere outside the 5 boroughs of New York City, you can contact New York eHealth Collaborative, or NICE. Again, these services are free, and we encourage you to contact them for assistance. Please contact our support team at 877-646-5410 if you have additional questions or need assistance. You will find our website here at www.health.newyork.gov/EHR. We want to thank you for attending our webinar today, and please feel free to contact us if you have any questions.